I am thrilled to be here today, and I'm thrilled to see so many people interested enough to be sitting in those seats, ready to hear more information on the ketogenic diet. And I feel honored that I get to talk about something that's as important to me as the ketogenic diet for cancer. That is what I specialize in, and I've been doing it for about 10 years now. So I've worked with a lot of people. I want to make it clear. Can you hear me okay? Okay. I want to make it clear that the ketogenic diet is not a standalone therapy. It does not cure cancer. It should be considered as an adjunct to whatever choice the person is making. It is all about the choice. So a lot of people do choose to go conventional care, but I also support people who choose alternative therapies and are trying to combine different therapies. I don't make any judgments on it. I just do what I can to help them with the diet. I've gotten to know many of you over the last few days because I was here for the ACN conference, and I know that people want a set of guidelines that they can look at reliably, feel very comfortable with, and I'm sorry to say that's not going to happen today because we're still just building this, and I know so much more now than I did 10 years ago, and I will know a lot more 10 years from now. So it's a constant state of learning for me. I actually was up late last night, still changing some aspects of what I'm presenting here today. And I want to, like Dr. Poff did, address the difficult part of this. I talk a lot with families about how challenging this is, and I hear what doctors have to say about it, that it's too difficult, too difficult, you shouldn't do it. But let me tell you, the standard of care in cancer is not easy. And so it's just a loss of perspective that they have on what might be considered challenging or difficult. This diet for people can be a walk in the park compared to what they are either going to face or what they've already been through, and I know that from personal experience. I'm working on a course, and we will have something on ketogenic diet so that people can learn more in a more structured way than they can in a presentation. I do want to say I've packed a lot of information into the notes in my slide presentation. I don't know if you get to see those when you go through my presentation, but if you don't, just email me and I'll send you a copy that has the notes that are readable to it. I also want to say that I have a book scheduled. Dr. Poff was kind enough to put my current book up there. That is really for clients. I call them clients because I don't work with patients. But my new book that's coming out in June of 2017 will be a handbook for practitioners as well as patients. Going here. Disclosures are pretty basic. I'm a nutrition consultant, so I am hired to do certain things, and I've had the pleasure of speaking in a few places. And Dr. Poff didn't mention, but there's going to be an amazing conference coming up, Metabolic Therapeutics in Tampa, in February. That's not working. Okay. In February 1st through the 4th, you can go online and look at Metabolic Therapeutics, and Dr. Poff is organizing that conference, and she did a wonderful job with it last year, and I'm confident she will this year as well. I guess we had skipped over that. So there's again, you can read this on your own when you have the slides, if you have this interest. So I want to move on to the founding fathers. So Dr. Otto Warburg was looking at cancer cell metabolism at the beginning of the last century, and what he observed was that cancer cells upregulate glycolysis, which is glucose fermentation in the cytoplasm of the cell. I hope I'm not being too basic for people. Even in the presence of oxygen, the presence of oxygen would suggest that glucose would be more efficiently metabolized in the mitochondria of the cell. And he was awarded the Nobel Prize for this observation, and actually the observation has never been in dispute, but over the years, cancer research has begun to obsess on the role of mutated genes instead of looking at the disrupted metabolism of the cell. And that's a huge failure, and we're going down the wrong road with that. We're spending a lot of money and coming up. You can't address every single cancer-promoting pathway with a new drug. It just isn't going to work. So early in this century, our other founding father, Dr. Thomas Seyfried at Boston College, it's a very interesting story, but he got into, kind of sideways through the epilepsy world into looking at the potential of a ketogenic diet for brain cancer, and published his papers on that. Well, the one that I came across, the one that got me interested, was in 2007 in the spring. So you see how short a period of time, that's just over a decade ago, that this has been out there, and how huge it's gotten since. So what Dr. Seyfried is saying, his theory is that cancer is primarily a metabolic disease involving disturbances in energy production through respiration and fermentation in the cell. And I'm hoping that I can go to his Nobel Prize ceremony. Books. These two books are really essential if you want to get into cancer as a metabolic disease. Dr. Seyfried's book is very technical and gets into it very deep. And actually, it was published in, I think, 2012. And there's a lot of new information since then that's come out. But you can get there through papers that are online. And then Travis Christofferson came out with a book called Tripping Over the Truth, and it reads like a novel. And it's a really great book to read to get the background on cancer as a metabolic disease. The other two books that I really recommend highly, Dr. Poff had one of them up there, and that is Dr. Volek and Dr. Finney's The Art and Science of Low Carbohydrate Living. That's the one that nutrition professionals should all have. And then when somebody has a question, you just look it up in there. And you'll learn, every time you pick that up, you'll think that he wrote something in there new for you that day. And then the other book is The Art and Science of Low Carbohydrate Performance, and that's more of a short manual for athletic performance, but I find it very helpful with clients. Neither one of those is cancer specific, but it doesn't matter because the underlying information about ketogenic is so very important. So what is the evidence to support speculation that a ketogenic diet can impact cancer cell metabolism? So no drum roll here, because this is what we've got. We've got the mouse model research, which that's what drew me into it in 2007. And Dr. Poff has published some papers on that, and there's some work coming out of Barrow Neurological as well. And I'm sure I'm missing some other things, but these are the people I'm most connected to. We have some published papers as case studies, and we're getting more of those. Literature reviews, and some data that's coming out of clinical trials. There are ongoing clinical trials, and you can easily find them. There's pre-publication data coming from the ongoing research, and there's the shared clinical experience, and boy, I wish there was a ton more of that. We could use a ton more of that. So Dr. Poff discussed this, the macronutrient distribution, standard versus ketogenic diet, and she did it in a diet ratio, which is the classic way of coming at it from the epilepsy world. And actually, that a lot of the early research, that's what they also do, is the classic ketogenic being a 4-to-1 or a 3-to-1 ratio. But with all the information that's online, and a lot of it coming from the performance world, they're talking more about macronutrient distribution, or macros. So I decided that in my presentation I was going to focus on macros and not diet ratio. And so there's this, we're comparing the standard versus the ketogenic diet macros. And in the standard, you're looking at fat, a standard diet with, this is the guidelines we're used to, 20 to 35% fat, protein at 10 to 35%, and carbohydrates at 45 to 65% of calories. So this is all as a percentage of calories. Whereas with a ketogenic diet, I just did averages. So I have 78 to 86%. Most of the people I work with are going to fall into that group, and that's why I use that distribution. Protein, again, most people that I work with, 8 to 12% on the protein. Carbs, most people I work with, 2 to 6% on carbs. This can change depending on individual needs. And one thing that's going to change it up some too, I know, but it's just not there yet, is the ketone supplementation, the exogenous ketone supplementation. So this is where we were at for a number of years. Cancer cells, love glucose and insulin. So most of the people that contacted me early on, and still today, are going, oh yeah, they're going to starve their cancer of glucose. But what we do know about cancer cells is that they have more glucose transporters and more insulin receptors than normal cells. And this is a really important thing, because this is like an upregulation of their fuel pathway. They're getting more glucose by doing this. Cancer cells take up glucose at a higher rate than normal tissue, and that was one of the initial studies back in the 90s. It was a case report, 2 pediatric patients, Linda Nabling, and she published this in the College of Nutrition journal. So that was my first paper that I read, actually, after Dr. Seyfried's paper. And you can see this clearly, and she did this too. She was able to see that there was just after 8 weeks on the diet, there was reduced 21% in both of these children, reduced glucose uptake at the tumor site. How that translates into disease management, not as clear cut as the reduction in the glucose. So the ketogenic diet exploits this relationship. This is something we also know. Cancer cells love glutamine. And this is a very tricky thing, and I'm glad we have smart people like Dr. Seyfried and Dr. Poff and Dr. D'Agostino that are working on this problem here. Because we need glutamine. There's no question our bodies need glutamine. It's important to immune function and for a number of other things. If we don't take in enough through diet, we're going to take apart other amino acids and we're going to build glutamine. But glutamine can serve as a substrate in the TCA cycle. That process is called glutaminolysis. And glutamine products are involved in tumorigenesis, proliferation, and disease progression. So that makes glutamine a double-edged sword. I wish I had some time to go into it, but more of that. But if you start following Dr. Seyfried's work, you'll see what he's doing currently. So ketogenic diet is going to exploit this relationship as well, because remember, we're keeping protein low at 8 to 12%. And I do have that talk about glutamine with people, but I don't want them to get phobic about it. So the way I approach this is it's not just about the ketogenic part. You got to do more than just ketogenic in order for this to be an effective cancer management strategy. So I see it as a 3-pronged approach. And there's the carbohydrate restriction, and that's what we think of as ketogenic diet, is a carbohydrate-restricted diet, and that's the part that's going to induce ketosis, and that's really important for all the reasons Dr. Poff laid out for us. And then there's that managing the amount of protein. We can call it a goal or a threshold or a target. It doesn't really matter what we call it. It's going to be lower by about half than what most people currently eat. But that is going to also help limit cancer cell proliferation. And I'll tell you, it's a really important part of brain cancer. Not so important, at least in my experience, not so important in some of the other systemic cancers, but really important in brain cancer. And then the third part of that is calorie restriction. I know Dr. Seyfried feels very strongly about calorie restriction being a part of it. And if you're coming into you're discovering you have the disease, and you're, like most adults are, going to be slightly overweight at least, you may be able to do calorie restriction for a couple of months, and if you can, well, that's great. But if you can't, if you're already malnourished or have other issues going on that won't allow for that kind of caloric restriction, then there are other fasting regimens that I'll be talking about. So I know this is a bit of a dense slide, but I'm going to walk you through this. So the impact of carbohydrate restriction in cancer, this is what we're looking at. Lowers the amount of glucose available to tumor tissue. That's number one. It reduces the glycolytic rate, which dampens the glucose. It reduces glycolytic rate. Okay, that's happening in the cell, but it also dampens the glucose and insulin spikes, and that's more of a systemic reaction to lowering the carbohydrates. There's less fermentation in the cytosol of the cell, so there's less lactic acid being produced, and lactic acid is very toxic to cells. So they do a great job at pushing it out into the tumor microenvironment, which raises the acidity of that environment. And what does that do? That allows for tumor progression. And with less lactic acid being produced, also there's less of it being cycled through the Cori cycle and being reintroduced into the body as glucose, which is what that cycle does. Lower insulin levels through carbohydrate restriction, glucose restriction, it lowers insulin. And that is associated with lower levels of IGF-1, and that is a huge cancer-promoting pathway. Restricting carbohydrates will shift metabolism from the reliance on dietary intake of glucose, and like Dr. Poff said, then the liver takes over and the kidney to some extent in creating enough glucose to meet the needs of certain tissue, like mature red blood cells don't have mitochondria. They are totally reliant on glycolysis. That's why they only live for a few months, and then they need to be replaced. They get worn out. And there are a few other tissues too, like mature lens tissue, that are exclusively glucose users. So then you do this, and after a couple of days, you've depleted your glycogen. You've done this little dance of beginning to increase gluconeogenesis, which is going to take over glucose homeostasis for you. And then you're moving into ketogenesis. You're making ketones, and you're making them in the liver primarily. And they're going to provide the fuel, like Dr. Poff said, for the brain. And real important. We need that. So this is just a basic graph. I did a 24-hour glucose insulin, and I did it as most basic, which is, okay, this is how people normally eat, kind of, in the standard diet. It's 3 meals a day, and I'm assuming a 12-hour eating window. They eat breakfast at 7 in the morning, and they finish dinner at 7 at night. And those are the predictable glucose and insulin spikes that you're going to see. And then you see it kind of levels out overnight, and then the dawn effect, the production of cortisol in the early morning hours is going to raise glucose and start the cycle again. Well, in a ketogenic diet, and again, I'm being very realistic here, and I'm comparing apples to apples. I also did this as 3 meals over 12 hours. And you see that there's a rise, but it's more of a gentle wave than a spike. And we could actually make some changes here. And if you went back to the standard diet and added snacks, you'd see a lot more spikes. And if you went to the ketogenic diet and this was a child, you would see a much flatter line. Kids are incredibly metabolically flexible. They get very low glucose and very high ketones almost immediately after starting the diet. So, and the other thing that would change this out is if you employed daily restricted feeding, otherwise known as intermittent fasting. So instead of that 12-hour eating window, if you had an 8-hour eating window or 10-hour eating window, you would see a lower, flatter glucose insulin overnight as well. So the second prong of, I'm going to catch up here with my notes here too. The second prong is the protein. So how much is enough without being too much? If you got the answer to that, pass me a note, because I don't really know. It's going to vary so much from individual to individual. A lot of people I'm working with are just coming out of surgery or in a catabolic state, and they are going to need more than somebody who is basically healthy and gets a diagnosis of cancer. So it's not as extreme as what I'm showing here. But the RDA may be not the best indicator. The RDA is 0.8 grams per kilogram of body weight. But why isn't it ideal body weight? Why are we looking at total body weight when so many people are carrying some excess weight? And also we know that ketones are protein sparing. So I hope that research over the next few years identifies a good range. And I think ketone supplementation will make a difference there too. So, and here's the third prong. So if we're looking at that three-prong approach, we have caloric restriction, but without malnutrition. For those of you who were here earlier in the week, someone in their PowerPoint had a slide of a child that in starvation, it was a child with type 1 diabetes, and just totally body wasted. We're not going there. We're not even going to moderate malnutrition. So instead of caloric restriction, I like to call it caloric control. And when I work with people, I don't really talk about calories. I talk about that macronutrient distribution, and the calories fall where they are. I'm looking at them, especially in the beginning, to make sure that there's adequate. I don't like to see anybody getting below 1,200 calories for a woman or 1,500 calories for a man. And again, that may not be something that's set in concrete. It's certainly going to change. Maybe somebody has some existing metabolic issues, and we're going to go different for them. But caloric restriction, there is a body of research that cites some very positive metabolic effects. There's a whole group of people who practice it for longevity. The data that we have on, there were two studies that were done on monkeys, and the monkeys had a healthier lifespan. They didn't live any longer, but healthier lifespan is not a bad thing to have either. So with calorie restriction, there are hormetic effects. And I know that's been talked about a couple of times, but I didn't know if everybody's up to speed with that is. Hormesis, we can call that an adaptive response to stress. We are biologically capable of adapting to a certain amount of stress. If not, we would perish from the radiation in our atmosphere. There's a number of other things that would do us in rather quickly, but our bodies will adjust to a certain amount. Even ROS will adjust to a certain amount of ROS. We need that, in fact, for signaling. And so that adaptive response, though, there's kind of a sweet spot for that. You want to have enough so that you are causing that adaptation within the cell, but not so much that it's going to overwhelm the cell. And so a protocol, like a metabolic protocol that might be good for somebody in their 20s might be a disaster for somebody in their 80s. So this is all stuff we need to get up to speed with. And then, of course, with calorie restriction, you have the calorie-restricted ketogenic diet. And that's where it started with cancer. It was always a calorie-restricted ketogenic diet. Dr. Seyfried's work had shown that ad libitum had some issues, but we're learning that there are ways to do ad libitum as well without having those insulin resistance issues. So water-only fasting. This is really hot online. You'll see a lot. There's a new book out. Dr. Jason Fung with Jimmy Moore has a new book out on fasting, and there are some known benefits to it. And in cancer, a lot of times when people first contact me, they are just so, there's no other way to say it, they're just sort of freaked out that this is happening, and they want to do something immediately. They want some control back. They just lost control. They just heard that they have a cancer. They lost a certain amount of control, and they get it back by immediately stopping eating because they think this is the way to go. And actually, it's not a bad plan if they're ready for what happens at the end of the fast. So you can't just fast and then go back to what you were doing. You have to have a plan that extends beyond the fast. The benefit to a fast is that it's going to make that you're going to deplete your glycogen much quicker. You're going to get into that ketogenic state. You're going to get through the transition, even though it may be rockier transition. You're going to get through the transition a lot quicker But, you know, I put a lot of sort of qualifications on who I want to see starting a fast. So I don't want to see someone who's the only adult in the home starting a fast. I don't want to see somebody who has the responsibility of young children in the home starting a water-only fast. There's too many things that can go wrong. And we also have to look at the impact of the immune system. Is this person starting with a decently healthy, they have cancer, so there's some impairment in immune system or surveillance, but are they starting with a decently healthy immune system? If not, it may have some negative impacts. So don't need to spend much time here. Dr. Poff covered all this, and what I could add as far as cancer is that the dysfunctional mitochondria in cancer cells are not as metabolically flexible as normal cells. And you see, I didn't mention this, but I have a lot of references here, and so at the end of the presentation, there's a couple of slides with just some click-throughs that you can get to these papers that I'm referencing here. And I also have a toolkit of resources that is at the end of the presentation, too. So I hope you take the time to look through that and all the information that's in the slides. So the three-pronged approach gets us here. This combination of nutritional strategies is going to change. There's these epigenetic changes that we can look at right here. So the red truncated lines are the pathways that are associated with progression that are going to be inhibited by employing these dietary strategies. And the green arrows are the pathways that are upregulated, and these are all just considered healthy adaptations. And these are, for the most part, epigenetic changes from what was going on in those cancer cells, or in the other cells too, not just the cancer cells. This is improving your whole system. It's not just working on the cancer. So where do you start with a ketogenic diet? Where do you begin if you're doing this for cancer? There is information online, but most of it is not very specific to cancer. In the resources, I have some cancer-specific ones. So this is where you're going to start, is with a well-designed intake. And I know all of you that work clinically have an intake, and it reflects your personality. And it's going to gather the information that you need to get going. Absolute contraindications, those are, as Dr. Poff pointed out, those are inborn errors of metabolism that are generally identified in childhood, so they're not much of an issue. She gave you the list. Also, I have a link through to a consensus paper that also has that list of absolute contraindications. I don't fret about those too much, except for one, porphyria. That can develop in adulthood, and that is one that is a no-go for using this diet for cancer. The relative contraindications, I have a much longer list. It's huge because there's a lot of things going on in cancer. So going back to what Dr. Poff said about liver, so liver damage is going to elevate liver enzymes. But how far are they elevated? Are they just slightly above the norm, or are they off the charts, indicating really serious damage to the liver? That's a consideration. Steroid use. A lot of people I work with have to take, at least in the beginning, they're taking dexamethasone. Is that an absolute? No. 2 milligrams, 4 milligrams a day, we can still do this diet and have it be therapeutic. 24 milligrams a day, not likely. Prednisone at 100 milligrams, not likely. So the relative contraindications may just be temporary things that can change over time and get people. The first thing to do would be just to get anybody off of sugar, and then you can work from there. So I also I get in my intake, which is very basic intake. I don't want it to be like I said, I work with clients, not patients, so I don't want it to be an obstacle to them getting started. But these are the things, demographics, the diagnosis. I want to know what interventions they've done, what they're looking forward to. I want to know comorbidities and how they interact and what medications are involved. I like to look at labs and reports and scans. I don't order anything myself, but I hope they're working with a doctor that will. And I look for red flags in those. And I also look at the degree of support that they're going to have. If this is a very compromised person, this is going to be a much harder transition to make than somebody who has a caregiver who's going to do the meal planning and do the shopping and, and do meal preparation, and they just have to sit back and be taken care of. So, you start with that information. Then the other information I want, of course, being a nutritionist, I want to evaluate nutritional status, and if they can get the labs drawn, that's great. If not, and a lot of people can't, we still are going to move forward with this. I ask questions about appetite. I want to know about GI function, food preferences, allergies and aversions. And, as Dr. Poff talked about, the culture and religious considerations for diet. Meal patterns and timing. I want to know, what are they doing now? When are they eating now? How regular are they eating? How many times a week are they going out? How soon after they eat dinner are they going to bed? So the obstacles and barriers are many, and it's often a combination, not like one single thing usually that is a stopper for people, but it's a combination of things. I can think of a woman who was in her 80s when she contacted me. Her husband in his 80s as well. She had just been diagnosed with a stage 4 metastatic cancer, and her grandson had put us in touch with one another. She and her husband lived at home with no support. There were stairs in the house. She had a couple of things going on. She had osteoporosis and hypothyroidism, but those were not a big issue. She had no gallbladder, again, not a big issue. And the things that were working in her favor was that she was bright, she was cognitively all there, she was very sharp, and she was, as Dr. Poff said, there's some companies starting to do some meals, and she had gotten a hold of, her grandson had gotten a prototype set of meals sent to her. So she had some pre-prepared meals to start with, and she did great. She was only able to stay with it for a couple of months, though, because her cancer therapy involved a protein kinase inhibitor, and it gave her diarrhea, and it was intractable diarrhea, and she came off. But what she said to me when she came off at 2 months was that she had learned a lot and was making better food choices. And I also think just being with it for 2 months was the reason why she had just an outstanding first, kind of ongoing monitoring scan. Equating food with love. This is not serving us well. It's not serving any of us well. Comfort foods are huge in cancer. What do people want to do for you when you're diagnosed? They want to bring you things, make you feel loved. And then just our society, look at what's coming up, Thanksgiving. You can have the turkey. But these emotional connections to food do undermine compliance. It's one of the big problems. So one of the things you need to do to help people with is to change the conversation, to start to view food as fuel, and find ways, work with them to find ways that they can get their comfort elsewhere. So these guys, I am not here to disparage healthcare practitioners. I just want you to know what is most likely to happen between a patient and the doctor. There's that first guy there. He's the low info guy. He's going to say something like, diet doesn't matter, eat what you want. And he's not going to offer any support. The next guy now, that's a little bit more of a problem there. He's going to tell you with certainty that there's no evidence that this is therapeutic. And some people find it hard to stand their ground there. But this last one, wow. This one's a huge red flag. When somebody gets into eye-rolling, bullying, intimidation, it is a red flag for how they're going to be treated during the course of their care by this practitioner. And my suggestion is you don't have to change groups. You can usually just find another doctor within the same group that you'll be more compatible with. Some people do change centers. They've had such a bad experience with it. So, okay, what are the skeptics saying? Diet doesn't matter. Eat what you want. Go for it. You need to eat a balanced diet. Well, I think those wolves are eating a balanced diet. They look like they're doing okay. And in fact, there's a recently published case report, and again, it's in my references. And it was a woman who, on her own, decided to adopt a meat and fat diet. She had heard about the ketogenic diet. She had soft palate cancer. She knew what her prognosis was poor. She didn't want to put herself through all of that poor quality of life, so she figured she'd get what she got. And it's really very uplifting, so I hope you take the time to read that. And what was even more uplifting was she got the support from her medical team to do this. If there was evidence, I'd read about it in my journals. So let me translate this for you. My idea of evidence is defined by my profession. Translation number 2, I'm not interested in what you found on the internet. You'll lose weight. Now, some of you might recognize this photo from yesterday. But weight loss may be beneficial for some people, because if you go back to the idea of caloric restriction having an impact, as a matter of fact, Dr. Seyfried has said very publicly that he thinks some of the effect of chemotherapy drugs is that there's the unintended weight loss that people experience because the drugs are so harsh on the GI. You can minimize it with a properly planned ketogenic diet. You can minimize this problem. They're all worried about cancer cachexia. So nutritional status, you got to monitor that, monitor immune function, and you want to be sure they're not losing muscle mass. You'll get kidney stones or gout. Well, again, like Dr. Poff said, you can be proactive with potassium citrate, proper hydration, and possibly, I don't know, this is an unknown for me, low oxalate foods. I don't know if it makes that big of a difference. And then there's the issue of gout. You will see a rise in uric acid, serum levels of uric acid, usually in the first month or 6 weeks. I tell people to look for this so that it's reassuring to them that this is a normal thing that's happening. And the information I got on that actually did come out of Volek and Finney's book, Art and Science of Low Carbohydrate Living. That's why, you got to have that book if you're doing this. So the reason why the uric acid levels go up is because ketones compete with uric acid for excretion in the urine. But what I've seen is even with high uric acid levels, nobody is like having a gout flare. And I have worked with some people who have a history of gout, and their numbers have gone kind of inched out of the high range and into outside of the normal range, and they're still not getting gout. It scares them to death, but they're doing okay. I haven't had a single person have a problem with this. And this is another one. You can't follow this diet if you don't have a gallbladder, and that's simply not true, and I don't think I need to spend a lot of time with this group on it, because you know that you can digest fats. It may mean smaller meals. It may mean digestive aids, like pancreatic enzymes that are high in lipase. Some people like to use ox bile. I think it causes diarrhea in a lot of people, so it wouldn't be my first choice. And then there's increasing the fats and oils gradually is important for somebody so they get used to it. And medium-chain triglycerides, as Dr. Poff brought up, especially caprylic acid, which is easily converted. And you don't need the action of either pancreatic enzymes or bile. Once MCTs hit the intestines, they just diffuse through the intestinal membrane into the hepatic portal, and there they go off to the liver to be converted to ketones. It's sort of the keto version of a candy bar, actually. A high-fat diet will raise your cholesterol, because this has been addressed too. It's a temporary rise, and for all of these reasons, I'm not really worried. And people need to set priorities. So if you have a cancer that is going to take you down in 14 months, are you going to worry that you're going to die of a heart attack? The diet will slow down the growth rate of the tumor, and that will make the treatment less effective. Well, what do you got there? You got somebody that's at least paying attention, but he's got some wrong information. This guy needs to talk to Adrienne Scheck at Barrow Neurological. She's got some really great data on that. And the person that sent this to me said that he found it grimly amusing. And I tell you, I don't find this amusing at all, because it just complicates life for families. So let's get down to the goals, the nutrition goals. The National Cancer Institute, I don't want to take the time to go through them, I'm running low here. But I think we can all agree that these are just great nutrition goals. And they do a version for patients as well. Again, we can all agree on these goals. But look how they put it into action. Use ice cream as topping on a cake. This is an actual quote from the American Cancer Society guide. This is a very well-intentioned person, and I don't mean to disparage, but, my God, we're not starting here, please. So we've got the keto food pyramid, and we've talked about that. I use an online tool to set people up, and the reason why I use this tool instead of some much more clinically relevant tool is that I want to train people to be responsible for themselves. And the Keto Calculator, which is in the resources, it's a free thing. You just go on and you're done with it in a few minutes, and it kind of walks you through the steps. I walk through it with people, and then it's just a preliminary calculation. A lot of times you got to make some adjustments depending on how they're feeling and how they're doing in the first days or weeks. The Keto Diet Calculator is the tool for children, whether they have epilepsy or they have cancer or whatever. Now, please don't start by working with children. Like Dr. Poff pointed out, you really need a full team. It's getting there. I'm blown away that it's getting there. But the Keto Diet Calculator was developed by the nutritionist for the Charlie Foundation, and it is the only tool to use to determine macronutrients for kids, in my opinion. Again, it's in the resources. In lines of getting people to record, the tool that I have found works best that I can have them do and MeMonitor is a nutrient tracker called Cronometer. Go online. It's spelled Cronometer. And it's a free setup, and it tracks the nutrient intake. So it will tell somebody if they're short in B vitamins. It will tell somebody if their omega-6s are out of balance with their omega-3 intake. Then people take that information better from it than from me. So I'm just going to spin through these because this is like specific to people who are really going to do this. But carbohydrates at 12 to 25 net grams of carb. Again, just going to spin through it. Protein, we've talked a little bit about that. Protein needs to be divided among the meals. You can't have like a protein-heavy dinner and skip it for the other meals of the day. And you are going to get an insulin response from some proteins. And it can be even, proteins that you wouldn't expect to have an insulin response for somebody who's metabolically, not coming into this in a very healthy way. Fats, people need to take in enough to meet the balance of energy needs, and encourage a combo of healthy fats and oils. Again, lots more information in the notes. Ketone supplements, this is such a new area. I have more questions than answers, but that conference in Tampa, I hope I'm going to hear a lot of new information. Accommodations, this is a lot of what I do. And on the left, the treatment-related ones, and on the right, health and nutrition. Be proactive, otherwise people will drop out before they've really had a chance to experience benefits. Troubleshooting, that people need to track glucose and insulin. I don't like to get too wrapped up in it, but there's some information on Dr. Seyfried's glucose ketone index that I have in the resources. And this is the stark reminder of why we need to do this now instead of waiting for it to become evidence-based, because most people with cancer don't have the luxury of time. So moving forward, collaboration, learning opportunities like this, and a certification process, these are all very important. And then I'm going to get to the last part here, and my apologies, but I need to read this because this is hard. I want you to meet my son. He's a beautiful little boy. I think we can all agree on that. And he was diagnosed when he was 4 with brain cancer. And we were done with options. He was being moved to palliative care at the age of 7. And it was just days before that was about to happen that I found Dr. Seyfried's paper online. We had 6 more years with this incredible little guy, and we weren't in treatment. He wasn't spending all his time in an oncology treatment center. He was spending time playing with friends, going to school, camping with us in Mexico, spending lots of time at the hot springs. So I used to say, if I knew then what I know now, things would have been different. But I've come to understand that if I knew then what I'll know 10 years from now, that's the game changer. Thank you for your time.